Good afternoon, everybody. My name's Sean Morrison. I'm in the chair of the Brookdale Department of Geriatrics and Palliative Medicine and also direct the Hertzberg Palliative Care Institute. And welcome to our 22nd annual Douglas West Endowed Lecture. Just before we begin, I want to acknowledge the passing of a very dear friend of Mount Sinai, Adele Block, who died one day shy of her 103rd birthday yesterday. Both Adele and her daughter Peggy, who sits on the Hertzberg Advisory Board, have been incredible supporters both to this institution and palliative care. So it gives me a great deal of pleasure to introduce the founder of our West Lectures and the co-chair of the Lillian and Benjamin Hertzberg Advisory Board, Suzy West. Suzy was first introduced to palliative care when she and her husband Doug, who this lecture was named after, were referred to Dr. Diane Meyer. And as Suzy said, it was the first time somebody had actually sat down with us, held our hands, and talked to us about what is meaningful and what his goals were in the setting of this serious illness. And shortly after Doug's death in 1995, Suzy endowed this lecture series. And that just begins the start of Suzy's contribution. She has volunteered in the Hertzberg Palliative Care Institute for 22 years. She co-chairs our advisory board. She and her colleague Betty Kerr organize a speakers advisory bureau, which sends our fellows out into the community to speak on geriatrics and palliative care. She serves tea and dessert to our families and patients on the palliative care unit. And she has been incredibly generous in her philanthropy. This past fall, she put forward a $150,000 challenge to supporters of the Hertzberg Palliative Care Institute. Now, the challenge ends in May, but as of last week, 250 donors had contributed almost $300,000 to her match. So, yeah. Putting my director hat on, the match runs till May. There is still time. But really, it's my great pleasure to introduce Suzy West, who will say a few words. Suzy.
I'm so glad to be here again after 22 years. And Sean took some of my speech away already, but I'm going to say it anyway because it's short enough. So I say hi, I'm Suzy West. Oops, well, I touched something.
I'm just hitting my slides.
Okay. And I welcome you to the 22nd Annual Douglas West Memorial Lecture in Geriatrics and Palliative Medicine. Each year, my family, friends, and the Mount Sinai community come together to remember my husband, Doug, and to honor Dr. Diane Meyer, who took care of him while he struggled with a serious disease. Her experience with Doug and my family in 1995 strengthened our determination to start a palliative care program at Mount Sinai. Since that time, we've come a long way. Dr. Meyer is now director of the Center to Advance Palliative Care, known as CAPC, which helps establish and guides palliative care programs across the country and internationally. Dr. Sean Morrison, as you heard, it now heads our Brookdale Department of Geriatrics and Palliative Medicine, and he's just incredible. Right?
No, it's not.
Most of the time. Just to highlight a few of our recent major accomplishments as part of our vibrant research effort, which Dr. Morrison heads, we provide data to influence national policy to help alleviate the burden of caregiving and the costs of serious illness. Every 2 years, our palliative care unit is reviewed by the Joint Commission, which establishes standards and accredits 21,000 health care programs in the U.S. We passed their review with flying colors. Our strong fellowship program continues to be the largest in the country. Our 29 fellows come to us with diverse medical backgrounds. Some are specialists in surgery, renal care, health policy, and emergency medicine. They go to spread their expertise in geriatrics and palliative medicine to other specialties throughout the nation. Today, we are thrilled to have Dr. Jeremy Boal as our speaker, who as a resident in 1995 founded Visiting Docs with Dr. David Muller. A visiting doc team goes to homebound patients who cannot come to the doctor's office. I wonder if they remember that many years ago, in the program's infancy, I volunteered for Visiting Docs, sitting on the floor in a very small office. I don't remember what building. That's why I don't remember. Filing. I remember just, and seeing things that today I wouldn't be allowed to see, I'm sure, because of all the HIPAA regulations. As you can imagine, today that program is in great demand. I believe Dr. Morrison will now introduce Dr. Boal. Thank you. Sure.
So next year we're going to get our scripted remarks coordinated so that we don't repeat each other, because you just took out most of mine as well. So I'm going to ad lib. It's just an extraordinary honor, privilege, and pleasure to introduce Jeremy Boal to all of you. I think most of you, he's somebody who doesn't need an introduction. He really is just an extraordinary individual who has dedicated his life, as Suzy said, beginning in residency, to improving the quality of care for people living in our community. As Suzy noted, he was a second-year resident when he and his colleague, that's David Muller, who's now the Dean of Medical Education on the far left. And Jeremy, is that Laurent Adler in the middle? It is. So this photo goes back to 1996. I think it's a lot. You'll see Jeremy's aged pretty well, because back then they didn't have color photography, it appears. But think about that. Internal medicine residency. Back when Jeremy was a resident, that was 70 to 80-hour weeks. And as an intern, recognized the need for people coming into the hospital, because that was the only way they could get access to primary care, was by an ambulance through the emergency department, and setting up to do something about it. I'm not sure when he slept throughout 3 years of residency. There are very few people who have been that innovative and creative at a time in their life where all you can do is think about how you're going to get through the day. He was innovative before Mount Sinai was innovation. As Suzy said, that was the original Visiting Doctors program. It's so big now that you can't put it on one picture. This is the Christmas card, because they can't get everybody together in one place because of how large the program has gone. This is what Jeremy, David, and Laurent birthed those many, many years ago, and our patients throughout New York are better off for it. I had the pleasure of working with Jeremy. He came, I told you I'm going to have a, so most people then go on and do a fellowship, which is a very, very hard year after their residency, become a specialist. Jeremy was in internal medicine, running Visiting Doctors program and growing it, and decided that he needed some expertise in geriatrics, and so he wanted to do a geriatrics fellowship. So he just did it on top of his full-time job. Yeah. I think Roseanne Leipzig was incredibly creative in figuring out how we were going to meet the ACGME requirements, but Jeremy ran Visiting Doctors, took care of patients, and did his fellowship all at the same time. Clearly, this is somebody we wanted to go into academic research, because that's where really, really smart people went back then, or were supposed to go, let's put it that way. And he tried. He worked with me for a while, and I will never forget when he came in and said, "This is not for me." And I said, why? And he said, because it takes too long to make change. And he made change. We lost him to North Shore LIJ in 2007, where he became their chief medical officer. That's now Northwell. And thank God we managed to get him back in 2013, 6 years later. He became the chief medical officer for the system, and then when the presidency of Mount Sinai downtown opened up, since he had fixed things at the Northwell end, we sent him south to fix things at the south end of Manhattan. He's now the president of Beth Israel Medical Center. He is the CMO. No, I take that back. He was the CMO. He's now the executive VP and chief clinical officer for the Mount Sinai Health System. Since becoming chair 7 months ago, I have had numerous meetings, phone calls, email conversations with Jeremy. They all begin with, how do we provide better care to our patients and families? How can we get better and do a better job? And how can we, as a health system, provide the highest quality of care? He's an unbelievable role model, and it really is a pleasure to introduce him to you today. Jeremy?
Thank you very much, Sean. I'm speechless, and that doesn't happen very often. Thank you. And to Susie as well, thank you so much for being our first volunteer when we were a mess, let's be honest. And you came in and helped us out and helped get us on our feet. I don't know how to turn this back on. Oh, there we go. Yeah, I think so. Yeah, thanks. Okay, so this is my talk. And it's nice to see so many familiar faces today, and it's really nice to see unfamiliar faces as well. I hope this is useful for you. I put a lot of thought into how to spend my time up here. I owe so many people so much who helped me navigate healthcare and do my work. And so many of them are in this room that I was really nervous, and I still am very nervous. Because I feel like this is a little bit like defending a dissertation, and I'm not an academic. So hopefully it'll be useful. We'll get back to why this is called the end of the beginning in a minute. Does anybody know what quote this is from? Just curious. All right, that's good. All right. There are so many people to thank in this room. Roseanne is one of them, Suzy, there's a million other folks, but I do want to just take a minute to thank the three people sitting right here, Sean, Al, Diane. I was a resident when myself and my colleagues wanted to get involved in doing something a little different. And we didn't know what we were doing. We just knew that there was a problem that needed solving. And Al and Sean and Diane, in addition to being all world famous in sort of moving the needle around complex care and relieving suffering and really changing healthcare in America, they have probably spent more mentorship hours than could ever be repaid, helping so many of us come up ourselves and develop the skills we need to develop and grow. And each of them, in their own way, did that for me and for my colleagues. And I've got many stories, some embarrassing for me, so I won't share those, but many stories about how they helped me navigate and grow as a leader and as a human being. And each of them is a role model to me and to many, many other folks. And we'll come back to this picture in just a little bit. So this is what Sean wrote me when he asked me to do this. He said, I was hoping you could speak both about creating health systems that meet the real needs of patients and families, and about your personal journey as a leader of system changes and innovations. So I'm planning to cover both those topics. How much time do we have, by the way? All right. So if we get through the first topic, I have a little bit on the second topic, if it's useful to you at all. I really want to spend most of the time talking about, creating health systems to meet the real needs of patients and families, because I do think that's the work. And there are a lot of things that work against that. Al and I were just talking right at the before this started today about some of the work that he's doing with Linda DeSherry and others to advance new models of care, and just how hard it is to change the system. And what makes it possible is people like Al and Sean and Diane and so many others who they just don't give up. That's what it takes. You have to show up every day and just keep pounding away. and eventually it starts to change. So the talk is called The End of the Beginning. I want to start at the beginning because I think it's important that we have some context for where healthcare is now and how far we've come already before we talk about how far we have to go. This picture was taken 100 years ago, 1918. 100 years ago, not a long time. We just heard about Ms. Bloch, who died at 103. This is one lifetime's worth of time. That's what healthcare looked like 100 years ago. And since then, this is just a small a set of examples of what's changed in 100 years. A lot of this in the last 50, and many things in the last 20. I mean, can we imagine a health system with all these without these things? Imagine what the system could look like 100 years from now. The pace of change is actually accelerating, and many of these things were developed. Many of these innovations happened in a time when people were driving Pintos, So just think about that. I mean, it's remarkable to think about how far we've come already. This is just one example. This is heart disease. We have some of our heart leaders in the front row today. And so this is going back to 1950, the deaths per 100,000 people, all the way through 2010, a little after 2010, and all the inventions and innovations that occurred over that time period. And we went from about 450 deaths per 100,000 people down now to about 150. And that's just one condition. This is, I know it's a funny title for a slide, The Conquest of Pestilence in New York City, but this is DOH data looking at deaths per 1,000 population going back to 1800. And again, you can see just this extraordinary improvement in our odds of survival. All those innovations, all those changes that have come before us. And along with that, obviously, comes this massive increase in our life expectancy. Back in 1900, the average life expectancy was 47, just over 47 years, and now it's 78 years. And of course, many people are living much longer. And many people are living disability-free and disease-free much, much longer than they used to. Pretty good, right? So why don't we just call it a day? I mean, that's pretty good. Are we done? Is it good enough? Why not? Access, suffering, cost. You just did my whole lecture. That's perfect, and that's exactly right. It's not enough, and I think we have to really. It's a little bit of a gut check. There has been so much that's come before, but there's so much that is ahead of us, depending on where we set the bar and what we're willing to tolerate and accept. And I know I'm in a room full of people who really set the bar very high. So this is a picture of Anna Blum, who is a provider in the visiting doctors program, taking care of one of her patients. And so all those innovations may have helped get this patient to where he is now, but there's an awful lot more that goes into life beyond surviving. And again, I'm talking to an audience of people who recognize that fundamentally. And I think the challenge for us has been that we have been working so hard to evolve the healthcare system in an environment where almost everything is stacked against us. Because the system has evolved in an environment where we have an ability to innovate and optimize in certain areas, and in other areas it's almost impossible. And it's because of the way our system is structured, it's the way our incentives are aligned and everything else. And I think we may be reaching an inflection point where things get easier to do some of the things that really matter on top of the innovations that are equally important. And that's what I want to talk to you a little bit about today. This article came out in 1982. This is Eric Castle talking about the nature of suffering and the goals of medicine. And I think it's just as relevant today as it was when it came out. We live in a reductionist society. That's how we solve problems. We go after a disease. We go after a problem, and we iterate on it until we solve it. And that's how we address heart disease, and that's how we address cancer, and that's how we improve survival rates. And that has been so valuable to us as a society and as an industry. That model has not done a terribly good job of addressing the nature of suffering, as Diane just mentioned, the multidimensional nature of suffering, and what we live with as people, spiritual, physical, behavioral, our communities, and everything else. And each of us knows this, I think intuitively, because we care for people. And we do some things incredibly well. And other things there's just no solution for right now, and we struggle against that. All three of these folks here have spent their careers swimming upstream against that. None of it's been easy. None of it. And they've made miraculous changes. And in fact, this headline, just from a couple days ago, I think, is an indicator of how much things have changed in just the 20 years that you guys have been at this, 30 years you guys have been at this. Seriously ill former First Lady Barbara Bush, 92, halts medical treatment and focuses on comfort care. This wasn't even controversial when it came out. It would have been just a few years ago. The idea of focusing on something other than just longevity is becoming normative in our society, and that's a really big deal. The context in which the innovations have occurred, the changes, these amazing changes have occurred in healthcare, are really important, and they've been important to help us get where we are, but they're not great at getting us where we need to go. And these are some of the fundamental misalignments that we're struggling with. We have grown up in a fee-for-service environment where we get paid for episodes of care and for procedures, not for caring for the whole person. So when you think about Anna taking care of this patient, there may be a list of 20 things that matter to that patient, only 3 of which may be things that we get paid for. But they all matter when we think about relieving suffering and we think about, supporting our communities. So visiting doctors back then, we could drop a bill to Medicare for a home visit, and we'd get paid about $70. And Anna would, she'd have to get to the visit. The visit might take 2 hours because when you're in the home, everything's in front of you and you've got to address everything. Then there's going home. There's the salary, there's the infrastructure and everything else. The insurance system never covered more than 1/3 of our costs. We knew it was the right thing to do, but it never covered more than 1/3 of our costs. And frankly, I can't blame the payers for that. That was the system, that's the system that we've always had here. It was the same for palliative care. Sean and Al and Diane and you guys, you had to work incredibly hard to come up with an argument for hospitals to pay for this. And you went where the money was. That's what we do, right? And you did it. You convinced the vast majority of hospitals in this country to actually build palliative care programs because you were able to fit it within the context of our current fee-for-service system. And it's practically a miracle when you think about, the direction you're going in and where the healthcare system is going in. But what we didn't do was we weren't able to build a robust ambulatory palliative care platform for the country because there was no way to create that alignment. And that's still a real uphill battle. And there's all sorts of other ways that we haven't been able to fill in the cracks in the system. We also grew up in a system where there was very little patient choice. Very little patient choice. There wasn't urgent care, there wasn't telehealth, there was the doctor's office, there was the hospital, and there was the emergency room. There was also, I think, very limited societal expectations for what we delivered. And thank God that's changing. The expectations are now much higher, that people expect, and they should expect seamless care. They should expect that their medical record follows them when they go, between sites. They should expect that at 2 a.m., if they have a problem, they can speak to somebody who can solve their problem rather than just go to an emergency room. And there was no transparency. It was impossible, and to a large extent that's still the case, for somebody living in our own community, if they have a problem, to know whether one hospital or one doctor is better than another to solve their problem. I'm in the industry, and I can't figure it out. But that's changing also because we're starting to unify around metrics, more things are being posted, the consumers are having more power in being able to tell their story, and people are using that to make decisions, and all those things are moving in the right direction. So the ground is starting to shift, and these shifts are not small. They're actually seismic. This is a slide from a colleague of ours, Niyam Gandhi, who runs population health for our health system. And I want to spend just a minute on what's happening, sort of the macroeconomics of funding in healthcare in America, because I think it's really important, and it's what's going to create some unique opportunities for us. The projected per capita medical spend is going up for a host of reasons. And again, you read this in the newspaper all the time, But just to summarize, the population is aging. We're increasingly unhealthy, and that's adding to cost. There's general medical inflation, and then there's a lot of new technology, new pharmaceuticals, new equipment, and everything else. And this is just one example. These are price changes against overall inflation from 1997 to 2017. And right at the top of the list, I don't know if you guys can read this in the back, is hospital services. Over 200% increase in the last 10 years. Inflation's only gone up 55%. Prices have only risen 55% based on inflation. Medical care services is there as well. The other ones that are interesting, I've got a 17-year-old, so it's very relevant for me. College tuition and college textbooks, right? Another area where the rules of economics don't apply for some reason. Healthcare, college. So there are no market forces for some reason in those areas. Meanwhile, everything else has plummeted. Software, toys, TVs, new cars, cell phones, I mean, you name it, it's all less expensive against inflation. Funding is becoming limited. This is new for our system. And this is a seismic change for healthcare in America. For decades, hospitals and health systems have gone to commercial insurers and said to them, you know, we're getting underpaid. For Medicare and Medicaid are underpaying us. We're going to force you to pay us more and more every year, and we're going to cross-subsidize Medicare and Medicaid in our health system. The private insurers, for years, have said, okay, and they just pass those costs on to consumers, us, right, and companies. And the consumers are pushing back, and companies are pushing back. You know, Ford's number one input into building its cars is not steel or aluminum, it's healthcare. It's the number 2 spend for most companies in America, healthcare. And so they're turning around and saying, we're not doing it anymore. So the whole system is starting to reach this critical point where the dollars coming in are not matching the rise in expenses. Employers are dropping coverage. Medicare is running out of money. You guys know this. Budgets at the state level are getting very compressed now as well. And the tax base is shrinking relative to the aging population. So all of those things are creating this change in the line with regard to funds available. That gap between utilization demand and the funds available is opportunity. It's threat. We get that it's threat. I want to promise you I stay up at night worrying about the threat as a hospital executive. But it's also tremendous opportunity because we can't just do what we're doing a little better and survive this, and that's what we've been doing for a very long time. Control costs a little more, do a little bit better on revenue, you know, attract a few more high-margin surgeons to the health system to keep the engine running. Doesn't work anymore. We actually have to change our business model to be successful. And not just us. America has to change its business model in healthcare. And that's going to create, and it's starting to create this window of opportunity to start to realign around the things that we care about. So this is the new context. It's tremendous cost pressure. Again, a threat, but an opportunity. One of the byproducts of that is that financial risk, which used to sit squarely in the insurer's pocket and in the employer's pocket and the union's pocket, is now moving to the healthcare system. So we are now in the position where we can turn to an employer or to Medicare or to Medicaid and actually take risk from them, which means we get prepayment. And we can take those dollars and spend them how we think they should be spent, not just based on each episode of care. Patients have more choice now, which means we have to compete differently for them. Their expectations are very different. And that means we can't ignore service and we can't ignore access anymore, because if we do, somebody will eat our lunch. Not just our traditional competitors, but all these new market entrants who are looking to figure out how to extract value out of the healthcare system. And a lot more transparency. And thank God now, the public is starting to have insight into where they can get better care, safer care, more cost-effective care, and the like. So that's really my message to you. We actually may have a burning platform right now for the first time, certainly the first time in my career. I've grown up in a fee-for-service system. It's never been this way. We've never had the ability to do this. When we built visiting docs, when we've made all these investments to grow palliative care and all these other things, all the hard work around new models of care, it's always been an environment where we've had to swim upstream rather than downstream. This new platform may create an opportunity for us to build holistic models of care for patients and populations. So here's kind of what we need to do. There's just 5 things. There's a lot behind each one, but I just want to give you sort of big picture how we think about it. The first one is, this is a little boring and wonky, but we have to align our contracting strategy with our goals for clinical transformation and become a population health manager. And that means that we have to start to redesign our work so that we can actually take responsibilities for large populations of patients and take prepayment for them and deliver exceptional care at the right price to them and take risk, which means if we do a really bad job of it, we lose money. That's why it's called risk. But when we take the dollars up front, we get to be very creative in how we spend them. And that's really the secret to all of this. And while we're doing that, we also need to still be an exceptional acute care provider for our own patients and for other people who pay for health care. We have to improve access to care. Diane mentioned this. In New York, right now, if somebody moves to New York today and they get a job with an employer and they get signed up with an insurance company through their employer and they need a primary care doc, good luck. They'll go on the website of the insurance company and they'll see a roster of physicians who supposedly take their insurance, and they'll start calling. And this one's full, and this one doesn't have an opening until Purim, and on and on and on. And you have no idea if it's a good doctor or a bad doctor, right? That's the state of the art. And by the way, we have more doctors than we need in New York, and more hospitals, and more beds, and more procedures, and more specialists, but people still can't get into care. And if it's Sunday night at 2 a.m., and somebody has heart failure, you guys know this better than I do, except for your patients, thank God. For the average patient in our market with heart failure, and they're trying to figure out if they're a little short of breath, if they should take an extra diuretic, or if they need to go to a hospital, they have no options. All they can do is go to an emergency room. And if they show up in an emergency room, they're probably going to get admitted. And if they get admitted, they're probably going to get a bed sore and they're going to get delirium. Then they're going to have to go to subacute rehab, and then they're going to be sicker. That's today. That's today. And I'm just using heart failure as an example, but access we've got to fix it. We have to fix it. We have to move complex care to high-volume centers of excellence. A little bit less relevant to what we're talking about today, but when we merged with the Continuum system, we went from 2 hospitals to 7 hospitals. 5 of those hospitals were places where you could get a pancreatic resection. And that's, for those of you who don't know, that's a really complicated surgery. Some of those hospitals maybe were doing 3 or 4 a year. Not good, not safe. There's no way the teams can maintain competency, the nurses and the physicians. It's why we don't do organ transplants in 7 hospitals. We do it in 1. When we merged with Continuum had a small kidney transplant program. They did about 6 transplants a year. We merged that into our program. We do about 200 transplants a year. So for things that are complicated, it has to be done in a place where we do very high volumes, where everybody has tremendous muscle memory for seeing every kind of complication and having the best equipment and teams really working well together. That's just as important as these other elements. We have to learn how to eliminate non-value-added variation in care. So the estimates are that somewhere between 30% and 50% of every dollar that's spent in healthcare in America is waste. And there's lots of kinds of waste, but one of the most prevalent kinds of waste is misalignment of how we use our resources and where the needs are. It's a huge issue for us. There are some people in New York, in markets like ours, who are frankly getting too much of the wrong kind of care. They see a specialist for everything, and they have to go to the top guy. That's what we do in New York. And the top guy may not be the top guy, but in New York, we're always looking for the top guy. And, it's like we go to the best Broadway show, and we go to the best restaurant. And you know what? It turns out that when you see a lot of doctors, you have a lot of things done to you. That's just the way it is. So in New York, if you have a condition and all the same comorbidities as somebody in Minnesota with the same condition, you will get approximately 80% more care here than in Minnesota. More specialty visits, more procedures, more x-rays, more hospital days, with no difference in outcomes and actually lower patient satisfaction. That kind of variation we've got to do something about. And a lot of it is about educating our community, and it's also changing the alignment. Because when we're getting paid for each of those things, we tend to do a lot of them. And here's the big one, and this is the fun one. This is where we come in. Invest and innovate to better manage high-cost patients and cohorts. So remember, if we're getting the prepayment to manage populations, and we know, and I think you know this, that it's a relatively small number of patients who are really complicated and have a lot of needs, and if they don't get exquisite management, they end up in the emergency room when they don't need to be there. They go to an ICU when what they really wanted, if somebody had spoken to them, was care that was focused on comfort and dignity. We can start spending money creatively to create better models of care. So just imagine what is possible when we have the first dollar and we're responsible for those lives. This is a slide that Lindsay Jubelt created. She's with our population health team. And this is actually looking at the various cohorts of high-cost patients that exist in our communities. There are a lot that are high cost, they're near the end of life, but there's other cohorts as well. There are people who get frequently admitted for a host of reasons: substance abuse, behavioral health, mental illness issues, unstable housing. There's traumatic events where people come in just for one, a high cost, inpatient admission. A lot of things around complex chronic disease, and then things like cancer and autoimmune conditions. They don't all need the same solution, and in many cases there are different solutions. But we can start to take this apart and figure out, how do we design systems around these cohorts of patients that provide them with care that keeps them well and at home as much as possible. Because we have first dollar, so we don't have to ask anybody's permission to do it. And here's an example of one of those. This is a program that was really, I think, it was developed or the seed of it was developed at Johns Hopkins, but it was really brought to scale at Sinai, here, by Al Su and Linda DeSherry and a whole bunch of people in the room. And this is the hospital at home model. And Sinai was able to get a grant for this while I was away at Northwell, to actually take patients who have hospital-level illness. So Medicare would say, yeah, they meet criteria for going into the hospital, and offer them the ability to get hospital-level care at home. And it works. And these are the outcomes. And it's not for everybody. The home situation has to be right. It has to fall within a certain kind of diagnosis and the like. But they were able to show a 29% reduction in length of stay, a huge reduction in 30-day readmission to an acute care episode, a big increase in patient satisfaction, a reduction in caregiver burden, and almost everybody was able to stay at home for their care. That's an example of what's possible when you really think about designing this around the holistic needs of the patient. It's also cheaper care. This is, it doesn't come out well, but this is their first patient, and we have permission to show that. So imagine being the first patient who got asked, would you like to have hospital-level care at home? She is very brave. Okay. I didn't mean that facetiously. So, and this program is, again, it's one of these things that is growing out of this department, along with a lot of other innovations that are now going to be scaled and spread, not just across our health system, but really start to really change how we deliver care as a system. And as Al was saying before to me, the clinical model is the easy part. It's threading the needle on the regulatory environment and the payer environment and all this other stuff. So that's why we became a health system. We didn't become a system. We didn't acquire Continuum or merge with Continuum just to be big. We did it because it's time to fundamentally change what we deliver to our community. And the only way to do that is to get to scale, to have enough inpatient capacity, but really to have enough ambulatory capacity and to cover enough geography so that when we go talk to payers and say, we want to take care of all your members, all your union members, all of your employees, all of your dual eligibles, we could say we cover a very big market. And we have services in all these communities. These are our physical assets you can see on there. The magenta circles are the hospitals. The dots are ambulatory clinics and other things. Picture on top of that all these new programs, transitional care programs and hospital at home and palliative care in the home, which is a program that Sean recently got funded that's going to be bringing new palliative care resources right into the community, right into the home. That's how we start to develop a much more holistic model of care for taking care of our patients in our communities. And that's why we put this ad out over a year ago. Imagine the Mount Sinai system. It's always been a hospital-based system saying if our beds are filled, it means we failed. That was us telling the market that we're serious about this. That doesn't mean we can't be great at, we can't stop being great at inpatient care. We have to be. But we can't just be great at inpatient care. So where do geriatrics and palliative care fit into this? I talked a little bit about, I think you get a sense that from my perspective, I think geriatrics and palliative care and palliative medicine have an opportunity to move from sort of a side salad to a main course in this new landscape, because that's what we spend all of our time worrying about. Everybody else worries about this stuff a little bit. This is all we think about and all we worry about. I don't think it's realistic for us to say we're going to have enough palliative care and geriatric specialists to deliver the care to every patient who needs it in this country. That's probably an unrealistic expectation. These are projected numbers of geriatricians in this country going out to 2050. And things may change, but right now, the estimate is in 2000, there were 4.7 geriatricians per 10,000 patients, 10,000 people, I should say, over 75 and over. Already, that's down to about 3.4. And by 2050, it's going to probably be closer to 1.5. Population's aging, and people are not choosing geriatrics. So the combination is creating, a much more limited supply and a much larger demand. How do we use our workforce? How do we think about our incredible workforce of people who worry and think all day long about holistic care of people in our community? Well, here's what we need to remember, and we should take tremendous pride in this because it's true. Geriatricians and palliative care experts are absolute masters of things that are extremely rare in our healthcare system and are vitally important. We know how to navigate systems of care. We do that all day long. Getting the durable medical equipment and figuring out the home attendant and which elder abuse agency and knitting all these things together and pulling in the family and putting it all together. We can't do our work unless we look at the whole patient and the milieu. We can't. Larry Smith used to say to me when we were started the home visit program, we took him on a home visit once and he said, Jeremy, you don't have a patient, you have a predicament. And I never forgot that. It's everything. It's nutrition, it's health beliefs, it's poverty, it's family support, it's everything. I think we're masters of navigation. I think we're masters of uncertainty. We're okay with uncertainty. Most people in healthcare aren't. Everything has to be, we have to get every single diagnostic test until we know exactly what we're dealing with. Then we can figure out what to treat. In geriatrics and in palliative care, we have to live with more uncertainty because all those tests impose a burden. And they create false positives. And, you can spend your whole life just, running around being tested and treated and all the rest of it. And so for us, it's much more about what are your goals? What are the goals of care of the patient and the family and everything else? And we can live with a little bit of uncertainty. We don't mind complexity at all. We don't mind having to integrate goals of care with the clinical illness and with, what this family structure is like and pulling that all together into some kind of model that does the best we can. And we don't mind reconciling differing viewpoints. That's part of the work also. You guys do that all day long. So patient wants X, husband wants Y, patient has a little dementia, daughter wants Z, right? The healthcare system, wants whatever comes after Z. It's just like, we're okay with that. Like, that's part of the work. And that's a lot of, treating patients holistically and communities holistically. And we really dig in on the ethics. And that's, again, you can't ignore it. We can't ignore these things. And we also, as we're developing new models of care, one of our most important jobs is to keep our patients safe. And so, figuring out how all these pieces fit together, I think, is something we're really good at. So I do think that geriatrics and palliative care is critical to our future. And I think these are just some examples of models of care that, there's more expertise in this room than probably anywhere in the country to evolve a better system that meets the needs of our patients and the like, and to really attend to models of care that focus on non-physical suffering. That's really important, and spiritual care. We also have the opportunity to help our people, our colleagues, our trainees, move into positions of leadership and influence in the healthcare system, because we bring all those skills with us, and that means we'll have opportunities to influence how the healthcare system of the future is designed. And there's so many ways that we can do that. Whether it's on the commercial side with insurance companies, whether it's technology, venture capital, because that's where a lot of these investments are being made. So influencing venture capital companies with regard to where they spend their money, pharmacy chains, physician groups, hospitals, you name it. And if that's something we think is important, then we should probably start thinking about how do we change our training paradigm as well. And you guys have done a lot of this already, and I think it's just continuing that work of thinking about what is the skill set? What kind of people do we need to attract into the field? And then how do we help them develop the skills to have maximal influence and not just be somebody who is great at taking care of individual patients? Because again, I think we're going to sell ourselves short, and I think we're going to sell the country short if we only focus on that. And by the way, I get how important academics are. I am just too bloody impatient, and I apologize.
Thank God for that.
Okay, so this gets us to the title of the talk. So this is Winston Churchill. I guess everybody knows that. It's hard to find a picture of him that isn't an actor playing him. I just want you to know that. Everybody wants to play Winston Churchill. So Second Battle of Alamein, it's World War II, it's 1942, and the Allies are losing every battle that they're fighting. And they're in the desert in Egypt. And at the first battle, they finally get a stalemate with the Axis. And the second battle, they win decisively. And Churchill, he feels like this is this moment in time where, things are shifting. Things have the potential to shift. And so, what he says is, now is not the end. It's not even the beginning of the end, but perhaps it's the end of the beginning. And I think that's very true for where we are in healthcare right now. We've had this extraordinary run of success in America and in the world. I mean, to think about how far we've come in improving survival rates and how so many people in this audience wouldn't be here, today if the system hadn't evolved so much. But we've had to do it in an environment where we haven't been the system hasn't been easy in terms of really focusing on the holistic, multidimensional nature of human beings and suffering and disability and family support and everything else. And now's this moment where I think we can marry this incredible spirit of innovation to really focusing on populations and the whole person, and really go from kind of swimming upstream, which is again what I think we've been doing. The current's going this way, and we've been working like crazy to make progress to an environment where it just gets easier. We can move faster, and we can move further, because there's just more alignment if we're really careful. So that's the first part. There's a little bit more on my personal journey, which is really awkward, that I'm happy to skip. But if there's time and you make me, I'll spend 2 minutes on it. All right, 2 minutes. So I'm not going to bore you with the details of like where I went and all that kind of stuff. But what? 2 is good. So, but I did want to, because you asked, because I would never say no, I did want to share with you a few lessons that I feel like I've learned along the way. That if I had to distill some key things that I've learned about leadership and about driving change, that over time have really sort of stuck with me. And so I'm just going to spend a few minutes on those. So the first thing is, 2 things to consider, 2 things that matter when considering a job. I've realized that, I've had a lot of jobs and I've done a lot of things. Here's what I think it comes down to. An opportunity to do meaningful work and an opportunity to grow as a person. For any of you who are curious about how do you make a decision about whether to take on something new, I personally wouldn't worry too much about whether it's an exact fit in terms of this is exactly what I want to study. It's this algae that I'm interested in, or this component of the system. If the opportunity you're looking at meets these two criteria, you probably can't go wrong. You'll probably grow as a human being, and you'll make a difference, and that will lead to other things. The second thing is, and this took me a very long time to figure out, when things don't go as I expect them to, stop blaming others. It doesn't matter how big the problem is. It really doesn't. The only useful time is thinking about what I could have done differently to influence the outcome. And it may be that I had to do things differently for the last 3 years to influence the outcome, or maybe it was just in the meeting. But this has really resonated with me over time. Number 3 is, and again, a lot of people who move into new leadership positions, they only know what they see on TV or what they think leadership's about. And again, this one it's a little subtle and it takes time to realize, but your title is meaningless. And command and control is absolutely meaningless. And giving orders is probably going to work against you. Leadership is mostly about creating an environment where people can do their best work, and I'll talk about that in a little bit. It's really important that we work hard to flatten the hierarchy and create an environment where there's just a tremendous and dynamic exchange of ideas. The people at the top are not smarter than anybody below them. By definition, the folks who are closer to the work are the smartest of all. And so the role of leadership isn't to make decisions. It's not to tell people what to do. It's to help people have a voice. These are 2 quotes I just want to share with you. The first is, this is from the Rickover Effect. So the nuclear navy, right after World War II, decided, one person actually, Hyman Rickover, felt very strongly that it was important to develop nuclear capability in submarines for deterrence during the Cold War. And he was adamant that it didn't create risk. Adamant. And to date, even to now, there's never been a nuclear reactor accident on a sub. In 10 years, just 10 years, they went from the only use of nuclear power being a bomb to totally safe nuclear submarines. Well, depends how you define totally safe, but safe for the sailors. It's never been done before. To innovate that rapidly, because they had to innovate everything. They had to create the casings for this. They had to take a bomb and turn it into power. The problems they had to solve were, if we tried today to do that, it would probably take us 50 years and we'd still fail. So people have studied how he did what he did. It's totally different than what you would think. There was no command and control, and this is one of his quotes. In my organization, there are no formal job descriptions or organizational charts. Responsibilities are defined in a general way so that people are not circumscribed. All are permitted to do as they think best and to go to anyone and anywhere for help. Each person then is only limited by his or her own ability. No hierarchies. No TOs. None whatsoever. It's hard. It's hard to I have found it hard to understand how they moved that far, that fast in an environment where there were no TOs and no hierarchies. But I think it gives us some insight into what's possible. The other one was, we talk a lot about high reliability organizations. These are organizations where, they could be very dangerous if things weren't done exactly right. So not just nuclear industry, but railroad industry, airlines. There's all sorts of industries like that where small mistakes can be catastrophic, and they've found the exact same thing. So what they say, and this is by Sutcliffe and Week, who wrote this book after they studied all these organizations. Rigid hierarchies have their own special vulnerability to error. To prevent this deadly scenario, high reliability organizations push decision-making down and around. Decisions are made at the front line, and authority migrates to the people with the most expertise, regardless of rank. And then the last one is, and this one again, it's taken me a very long time to appreciate, but I believe it's true. The most important question a leader needs to ask every hour of every day is, am I fostering an environment where the people around me can do their best work? If we ask ourselves that question on a regular basis and work on that problem, I think things accelerate. Our ability to drive change is amplified tremendously. That's it. That's all I got.
So, Dr. Boal will take a few questions. I just wanted to say one more thing, which I should have said in the introduction. As you can see, we have an incredible role model leading us forward into the new healthcare system. And for our 29 fellows, hopefully all of you who are here, this is the role model to be looking to. So thank you for that, Jeremy.
My dad's lecture, I'm also a nurse, and I became a nurse after 40. I've had other life experience. And I don't disagree with you. I'm working on a research study now, but I was on the floor for a couple of years. I really didn't see very much of what your vision is. And I wonder, because I have a life experience, would go up to execs, corporate who would come on the floor and say, hey, you guys are looking on our floor. I guess Jacob was coming or whatever. No one come up and said hello. And, and I said it nicely, but I wonder, how do you foresee, because one of the things, as Sinai gets bigger and bigger, I feel like these giant edicts go out to try and bring everyone on the same plane.
That's right.
Instead of having, I feel like it needs to be more and more specialized per unit, rather than these large proclamations like this is how it's going to be. Just the same way you talk about individually patient-centered care for every patient.
Yeah.
Every unit in the hospital, every division needs its own little mini plan. These things that make sense for REF, make sense for rehab or geriatrics.
Yeah.
Yet it's the same model. Part of that is EMR and all
Yeah.
that kind of stuff. And how do you envision that?
Yeah, there's a lot there, and by the way, I agree. I think we're at the beginning of this opportunity, and it's not guaranteed. Also, we have to work really hard to create it. Right now, we work in an environment that we all grew up in a system that behaves a certain way, the American healthcare system, and that system is highly punitive, and it's hierarchical, and it's very much about things that I believe won't allow us to reach our full potential if we don't evolve. There are examples of health systems nationally that have started to really make the change, and it doesn't happen overnight. It's going to be a process, but I think we actually have the ability to do it. There's more dialogue now at the highest levels in this organization about how important this is than there ever was before, than there even was a year ago. And in fact, we're going to be starting work this year around how do we change our culture? How do we transform our culture? And we brought in a lot of people from other organizations to help us learn to do this. When you talk about... So that's what I want to talk about. So the way that we're doing that is, that's part of it, is talking to the people who are doing the work. And to date, I think we've brought about 160 frontline staff into the process. We have a whole series of focus groups that are going on around the whole system, around defining what's a common purpose. The idea is that right now, if you ask 100 people in the organization what our common purpose is, you will guaranteed get 100 different answers. We don't have one. We have a mission statement, but most of us had no say in the development of that mission statement. We don't have anything to align around. So the first work is starting to create a common purpose, and then using that to create a visual representation of what our new culture needs to look like. After we do that, we'll actually be bringing people together. And by the way, nobody's exempt. We have 36,000 employees and thousands of physicians. We'll be bringing everybody together in groups of 10 or 12, and it's random, which means chair of neurosurgery is sitting next to lawyer, sitting next to somebody from environmental services, to actually start this work of resetting our culture. The other thing I'll say about when you mentioned about sort of specialization versus what's for everybody, we have to do both. We have to have one common purpose as an organization that we can align around, and we have to have one set of values, but within that, there has to be, again, because we do different things in different environments, we do have to have, different care pathways potentially, different strategies around how we manage our patients, but it cannot be built around us at all. And that's the problem we have today. It has to be built around the patients that we're serving. So.
Hi. I have to say, first of all, that you're very inspiring, and I think you are spot on, that there's a tremendous opportunity to match what really needs to happen in healthcare with everything that's going wrong now. I want to go back to your salmon versus trout. That I still feel very much like a salmon swimming upstream. And I think it's because you talked about being the master of complexity, the master of whole person care. And that's the skill set that's needed in the current environment. But we recognize that. I don't know if the cardiologists, the surgeons, the skilled nursing facilities, I don't know if anyone else recognizes that. So we're swimming upstream trying to say, hey, these are skills that you need and they can be learned and we're here to help you. But we're not getting traction where we're going. The fish ladder isn't
Right.
there.
I think that's the current state. I mean, you described it perfectly. We're not all aligned around whether these things even matter, or that it's all of our job. This is the work that's in front of us. We have a long way to go to get there, but I do believe this is the first time. Without changing the economic model, swimming upstream never ends. But when you change it, so I'll just give you an example. Imagine 2022. We anticipate having about 500,000 people that we're taking full risk on. And they're going to be all over our health system. And everything that we do to them that doesn't add value from their perspective wastes money and causes harm. And that's when we start having really difficult conversations with everybody, including our specialists, about why did you order that test? And, did you know that that patient is already on, another medication that, is in the same class, and you didn't bother to look at the record, and all of that stuff we start to accelerate the change when we're all aligned about what our job is, and the job is to take care of the whole patient. Because if we don't, this is the amazing part about it. In that model, if we don't, we bankrupt ourselves. We go out of business. We lose market share and we go out of business. So suddenly you get this alignment between what we need to do as a business and what's right for our patients. And that's new. We've never had that. We used to joke that, in the old model, and I'm not saying this about Sinai because we've always been very committed to these programs and to, doing the right thing. But in the industry, they say, that a CEO of a hospital worries about three things. Are my surgeons happy? Are my surgeons happy? And are my surgeons happy? And that's, in a fee-for-service system, you can't really blame them. But already, I can tell you, and again, it's at our board level at this point now, compared with where we were even 4 years ago, we spend as much time talking about quality, safety, and service as we talk about money. That's new. So it's not going to happen overnight, and it's going to take a long time to see it in all our microsystems all over the organization. But I think I would like us to recognize that we have an opportunity to get there, that things are changing, and we have to take the opportunity. Yeah. Yeah.
As you try to change the system, particularly for older people who have medicine delivered at home, for them to take care of themselves at home. I'm a big venture capitalist, and talking about reliance on people taking care of themselves or their family at home.
Yeah.
Certainly better than in the hospital. I am a venture capitalist and have invested in some of these methods. But I see two things I wanted your viewpoints on. One is that the average American family is not able to record a TV program, number one. Number two, and I've experienced this personally, that when you are ill or under pressure, your ability to function, even at your normal level, is much reduced.
Right.
And how can we accommodate the technical unsophistication in one area, the anxiety and pressures of illness on the other, to a system where we're supposed to be managing this ourselves at home?
Yeah, it's a great question, and I think one of the reasons so many of these efforts have failed is because people fall in love with the technology. They get this idea that works on paper, and then they try to ram it into a world that's much more complicated, and I think it's a mistake. Everything we do has to be purpose-built for the individuals that need the service, which means we have to take into account everything that you're saying. A lot of what we do, people say to us all the time, and we get this with Hospital at Home, well, isn't there just a technology solution? And because I think we want to believe there's just a technology solution. There isn't yet. I mean, most of it is still human beings, going to the home and having these important interactions and designing, a model that's purpose-built. And we all, I certainly believe that over time, we'll solve for some of these technology challenges, but I don't like putting them on the critical path for innovation, particularly around complex populations. I think it's a mistake.
If I might ask, on the other extreme from technology, where do you see a role for integrative therapies in this model of care, particularly as they can address sort of stress issues and quality of care and comfort and all of that?
Yeah, I think, again, the nice thing is when we're the payer, we can spend our money on anything that we think is going to make things better for the patient and still manage the cost. And so, there's multiple domains of integrative care that we'll probably look at and say, I wish we could have done this all along, but now we can. We have, and I don't want to go through them all, but they're there and available to us. We don't have to convince another payer that it's worthwhile. It's our dollar. There are the old PACE model. When it was first built to take care of dual eligibles in San Francisco, they built housing. It's our dollars. We can spend it on what we think is going to keep people well and out of the hospital and address their multidimensional needs. So that's where I think we can really be creative. Yeah. Sure.
So, just wanted to thank Dr. Boal one more time for just a really fantastic and inspirational talk. And I hope to see all of you again, same time next year.